ഒരു 2 minutes ജസ്റ്റ് ലൈവ് സ്ട്രീമിംഗ് ചെയ്യാണ്. ഓക്കെ അല്ല റെഡിയാണ്. Okay. Anila, shall we start the session? Anila, ഒന്ന് unmute ചെയ്ത് ചെയ്യണേ ഒരു മിനിറ്റ്.
Please contact security opening. Okay.
12 participants ആണ് സ്റ്റാർട്ട് ചെയ്യാല്ലേ?
സ്റ്റാർട്ട് ചെയ്യട്ടെ. അല്ല പറയുന്ന പോലെ 12 participants ആയി. One second. ഞാൻ അർച്ചനെ co-host ആക്കി. പിന്നെ the other presenter is Ragitha. Okay, Ragitha. ഒരു മിനിറ്റ്. One second. Co-host ആക്കി. One second. Okay. So I think we'll start. So a very good evening to one and all. Today we are presenting our flagship program. Our motto is Together We Learn. This is our Cloherty Clinical Pulse under the guidance and leadership of my mentor, my guru, Naveen sir. And we are presenting today the 9th learning series of the Cloherty Clinical Pulse, practice-oriented updates on evidence-based neonatology. And today we have a very interesting topic, that is tracheostomy in newborn. And the speaker is Dr. Anjana Dinaraj. Dr. Archana is doing her NNF fellowship in KIMS Health in neonatology department. And our moderator for today is Dr. Ragitha Binu Krishnan. Madam is consultant laryngologist in KIMS Health Trivandrum. So before we start off with the session, I would like to call upon our IAP Trivandrum President, Dr. Hari Prasad sir, to give the keynote address. Over to Hari Prasad sir.
So thank you, Binu. So again, we have met for yet another clinical pulse, that is the topic, various topics in neonatology. And I would like to congratulate Team KIMS for discussion. So today we have Dr. Archana to talk on it, and we have Dr. Ragitha to moderate the session. I'm sure this will also be a very excellent session. And I just want to give one message, because we always take care of the pain in newborns also whenever you do any procedure. So I hope you will, all the procedures in newborn are made completely pain-free. So with this request, I wish this program all success, and back to Binu to continue the proceedings.
Thank you very much, sir. Dr. Anila, can I invite Naveen sir to speak a few words, or shall we move on to the session?
Yeah, sir is here.
Naveen sir, I request Dr. Naveen sir to speak a few words. start?
I think we should continue with the program.
Okay.
Yeah.
Okay,
Sure,
sir.
sir.
Thank you, sir.
We'll start with the program, sir.
Okay.
Is the screen is visible?
Yes, yes. It's visible. Audible also.
Good evening to all who joined the meeting. Today I am presenting a topic on tracheostomy in newborns. I will start the presentation with a case scenario. The screen is stuck. Okay. It's a case of an outborn baby who came to us at 8 days of life. Baby was born as a term AGA baby without any antenatal or natal risk factors. The baby had respiratory distress soon after birth in the form of tachypnea and severe chest retractions and stridor. And they attempted intubation immediately after birth. And the baby became extremely comfortable in minimal ventilator settings, and extubation was tried after 24 hours. But again, baby had this similar respiratory distress and required reintubation with minimal settings. And after 72 hours of life also, this baby was attempted one more extubation. But since this baby continued to have this respiratory distress, and the baby was referred to us for further management in view of severe stridor, retractions, and repeated extubation failure. This was a baby. Here you can see this baby is having severe retractions, and stridor was also there, and we could barely hear the chest sounds or air entry because of this loud stridor. Initially, we attempted this HFNC, but in view of this persisting respiratory distress, we intubated the child. This is the picture after intubation. The baby is very comfortable even without any ventilator support with an endotracheal tube in situ. So we suspected some airway anomaly because after intubation and without any support, this baby is comfortable. We did a laryngology consultation and video laryngoscopy was done. It showed pooling of the saliva and some adducted vocal cord and restricted abduction of vocal cords. So a diagnosis of vocal cord palsy was made, congenital bilateral vocal cord palsy was made, and the parents were communicated regarding the same, and the baby was, tracheostomy was done for this baby. And the baby remained well and active post this procedure, and we could extubate the child on the same day of this procedure, and we could initiate and advance oral feeds, and we could discharge the baby in a stable condition. So, what are the indications for tracheostomy? The indications for tracheostomy varies by age group and are quite different in neonates compared to the older children or adults. The newborns requiring tracheostomy represent a special population. And in the immediate newborn period, congenital anomalies associated with some upper airway obstruction are the most common indications. The common indications for this tracheostomy in newborns are congenital high airway obstruction syndrome, Pierre-Robin sequence, where there is micrognathia, retrognathia, and glossoptosis resulting in airway obstruction, a vocal cord palsy as in this previous child, severe laryngomalacia, subglottic stenosis, severe BPD needing prolonged ventilation, tracheobronchomalacia, and in neuromuscular disease like SMA, where we may need prolonged ventilation and for clearing of these airway secretions and to prevent aspiration. Also, in some babies with some major recurring some major surgeries like for CDH, some congenital heart disease, etc., who need prolonged ventilation, also tracheostomy will be needed. So, at this point, I would like to present some a study which was published in a journal called Airway, where we retrospectively analyzed all neonates requiring laryngology consultation and fiber optic airway assessment over a 12 period between 2006 and 2018. Out of a total 90 neonates who were enrolled in the study, 20 had laryngomalacia, and among them, 3 of them needed tracheostomy. And regarding the outcome, all the 3 were decannulated in less than 2 years of age. And 16 babies had ocular palsy, and tracheostomy was done for 5, and 3 were dependent at 2 years, and we could decannulate 2 babies in less than 2 years. And for neurological anomalies with the swallowing dysfunction and all, 1 patient underwent tracheostomy and was dependent at 2 years of age. 1 patient underwent tracheostomy for Peary-Robin sequence, but the baby expired because this baby had multiple other anomalies also, not because of this tracheostomy. And for severe BPD with the subglottic stenosis and prolonged ventilation, 2 required tracheostomy, and both of them were dependent at 2 years of age. Broadly, the indications for tracheostomy can be categorized as 1 for airway obstruction, for assisted prolonged ventilation, to provide pulmonary toilet and or non-ventilator support, and to prevent aspiration. The indications for tracheostomy are changing. In the 19th century, most of the children or pediatric patients who underwent tracheostomy were for the infections like diphtheria or some foreign body aspiration, etc. But now with the advance in NICU care and more survival of this extreme preterm or babies with the congenital anomalies, the average age group of patients undergoing tracheostomy is decreasing. So some of the examples of indications for tracheostomy. In the first picture, we can see near complete glottis web obstructing the airway. The second picture, there is subglottic stenosis. Here there is bilateral vocal cord palsy causing airway obstruction. This is a baby with Peary-Robin sequence. We can see this small and receding chin, and which causes the airway obstruction. This child needed tracheostomy for airway management. And for severe BPD and for prolonged ventilation, also tracheostomy may be needed. So what are the challenges we face when performing a neonatal tracheostomy? The child is not a miniature adult. Airway is different in child compared to that of adult. There are some major differences are there. They have a prominent occiput. So extension of this airway may be needed with the help of a shoulder roll. They have short and chubby neck. And defining the anatomy may be difficult. Palpating and identifying this anatomy of this neck may be difficult in small newborns. Also, there is difference in orientation of larynx. The larynx in newborns is more upper and anterior compared to that of the adults. So in neck, the tracheal cartilages, more tracheal cartilages will be in neck for newborn babies. On an average, 10 tracheal cartilage will be there in neck in newborn, but around 6 tracheal cartilage will be there in adult's neck. Also, the level of cricoid cartilage is also different. It is at C4 level in child and it is C6 level in newborns. And the trachea is narrow and less rigid. Since it is more flexible, the chance of injuring the trachea during this procedure is also high. And the narrow trachea and airway. Due to the small airway caliber, mild stenosis or obstruction due to some secretions can also cause severe respiratory distress in babies. We all know that based on the Poiseuille's law, which holds that this airway resistance is inversely proportional to the 4th power of radius. So if there is a minimal narrowing, it may cause severe respiratory distress. And for babies, the smallest tracheostomy tube size, that is 2.5 centimeter of inner diameter. This may be bigger for a tiny neonate, tiny preterm neonate especially. And the availability of this smallest size tracheostomy tube may not be there in many centers. And few words about this tracheostomy procedure. This procedure is done under general anesthesia in an operation theater. and the patient is positioned with a shoulder roll with some neck extension, and the site where we do this incision is marked. It is between the cricoid cartilage and this suprasternal notch, and a horizontal or vertical incision. We do a horizontal incision. Skin incision is put, and anterior debulking of the skin is done because there is excess fat in neck. So after this removal of this fat tissue, this neck strap muscles are divided and retracted laterally. Meticulous midline dissection should be done because the pleura may be high in position. There is risk of injuring the pleura, complicating with pneumothorax, etc., and risk of injuring this major blood vessels or esophagus is there. So meticulous midline dissection should be done. And after identifying the trachea, we put stay sutures on either side of the proposed tracheal incision site. This stay sutures should have a longer suture length, the suture thread length, because we can retract this trachea by pulling these stay sutures on either sides. And incision is put between the second and fourth tracheal rings. And this tracheostomy tube is inserted, and the tube is secured with the help of this tracheostomy tube ties, and the stay sutures are labeled and taped to the chest wall. Post-operative chest X-ray is taken to confirm the position of this tracheostomy tube and to look for any complications like pneumothorax. So what are the physiological consequences of tracheostomy? This tracheostomy tube bypasses the upper airway, where this filtration, warming, ciliary clearance, and humidification of this inspired air occurs. So it bypasses all these procedures. So exposure to this dry air constantly can cause increased cough or drying of secretion, crusting, some mucus plug causing obstruction of this airway and all. So in patients with tracheostomy, we have to do filtration, humidification of the air, and frequent suctioning may be needed to clear the secretion and to maintain airway patterns. So that is that of the tracheostomy tube. The most important part in this tracheostomy is the post-tracheostomy care. This post-tracheostomy care starts from the theater sign-out itself. And the key concept of tracheostomy management is to ensure the patency of this tracheostomy tube. For every patient who undergo tracheostomy should have a tracheostomy kit nearby. Even if it is in the hospital, at home, or when traveling, a tracheostomy kit should be there with the patient. It should contain all the essential equipments needed for tracheostomy care, like this tracheostomy tube of a spare tracheostomy tube of same size and one size smaller, tracheostomy ties or tapes, this suction equipments, saline, syringe, etc. So how will you manage a new tracheostomy? That is the post-operative care of any tracheostomy care. We have to ensure that the tracheostomy kit is available. And for preparation, the patient should be in the supine position with some extension with the help of a shoulder roll. And when do we perform the first tube change? The first tube change is performed at around 1 week of post-op period, because this tracheostomy stoma maturation occurs at around 5 to 7 days, and after that only first tube change is performed. For airway humidification and filtration, what we do is we place a wet gauze over this tracheostomy stoma so that humidification and filtration occurs. And this babies initially will need frequent suctioning because of this increased airway secretions, and adequate pain management should also be done. And this cleaning of this tracheostomy stoma and inspect for any bleeding, signs of infection. The stoma care and all I will be explaining in the next slides. For humidification, When the patient is ventilated or on CPAP support, we have this humidifier. Otherwise, if the patient is extubated and breathing in room air, we can place a wet gauze over this tracheostomy stoma. These other methods like heat and moist exchanger and tracheostomy bib filter may not be applicable for small newborn babies. This is the tracheostomy heat and moist exchanger. It contains a hygroscopic paper which absorbs the expired moisture in the expired air and causes this filtration and humidification. This is the tracheostomy bib, where also this humidification and warming or filtration of this inspired air occurs. Sometimes we may need nebulized saline to provide additional humidity. So suctioning is the most important part in caring of a tracheostomy tube. So we have to train the caregivers, either the staff or the bystanders who are taking care of the child, all these basic tracheostomy care things. And for suctioning, we should teach them when to do suction. When to do suction means when there is any visible secretions or gurgling sound with features of airway obstruction, we can do this suctioning. We have to do for any misting and this air blast. If it is not there, we should do suctioning. And what size suction catheter should we use? For newborns, we use 6 or 8 French OG tubes for suctioning. And for babies, 80 to 100 millimeter mercury pressure is needed for suctioning. And this regarding this depth of insertion of this suction tube, it should not go deep into this trachea. Deep suctioning should be avoided because it may cause injury to the trachea with bleeding or future granuloma formation. So depth should be at or just beyond this tip of this tracheostomy tip. And it should be completed in 5 to 10 seconds. Prolonged suctioning should be avoided. And routine use of normal saline in the tracheostomy tube is also not recommended. If there is thick secretion occluding the airway and if it is not coming even after suctioning, we can use it sometimes, but routine suctioning is not, routine use of this sodium chloride for suctioning is not recommended. And regarding tube change, when to do this tube change? In this picture, this one is this Biona neonatal tracheostomy tube. This is the this one and this rush tracheostomy tube. These are the commonly used tracheostomy tubes here. We can see this obturator also. So when do we do this tracheostomy change? First tube change, as I explained, it is done at around 1 week or post tracheostomy, where at that time the stomal maturation occurs and we change this tracheostomy tube and stay sutures. And the second tube change for chronic patients who need prolonged hospital stay, like some neurological conditions, we do second tracheostomy change before discharge from the hospital. And after that, on an average, we do this tube change every 4 weeks. And for preparation of this tube change, we should make sure that minimum of 3 people should be there for any tracheostomy related care, because one person does the procedure, one person assists, and one person helps this tube equipments and all. We have to keep the child in supine position with a shoulder roll, and all the tracheostomy care kit equipments should be available. And we should ensure that this suction, this tube, this ties, everything is ready. And first we suction and clear this airway of any secretions. Then we remove this ties and remove this tube, while the other person holds this new tracheostomy tube and it is inserted gently into this stoma and tied with this tracheostomy ties around the neck. For tie changes can be done in with this stoma care also. It is generally done every 1 to 2 every 1 to 2 days, and when it is soiled, it can be done even before that. And minimum of 2 people should be required for this tie change also. And for tie change, we have to prepare 2 equal length of this cotton ties. And before applying before removing the old ties, you have to apply the new ties around this child's neck. And we have to, after securing this tracheostomy tube around the child's neck, then only we should remove the old tie. And regarding the tightness, we should not tie it too tight or too loose, because if it is too loose, there is risk of accidental decannulation. If it is too tight, it can compress the vessels or cause a neck injury. So the tightness should be around 1 finger. 1 finger gap should be there between this tie and the neck. About stoma care. Stoma care begins in the immediate post-operative period itself, and it is ongoing. So we have to inspect the stoma regularly for any bleeding, any signs of infection, skin rashes, any pus discharge, etc. And this cleaning of the stoma, we usually clean with some either a cotton wool applicator dipped in saline, or with the mosquito forceps and with this gauze. And we can apply a dressing between the below this neck flange to prevent any skin injury. For tracheostomy tube cleaning, it is cleaned in tap water, and we can dip the tracheostomy tube in soap solution for about 30 minutes to 1 hour to remove any thickened crusted secretions and all, and clean in soap water, tap water, and sterilize it. Routine use of this brush for this tracheostomy tube cleaning is not recommended, because it can cause biofilm formation. It can cause abrasions in the tube, can cause biofilm formation. So repeated use of this brush for cleaning is not recommended. And after sterilization, we can store it for reuse. This Bivona tube can be reused for up to 5 times. This feeding and nutrition is also important for every baby undergoing tracheostomy, because this there may be some regurgitation, some swallowing dysfunctions in these babies because of this reduced subglottic pressure, or this while swallowing, this larynx goes up, and this upward movement of the larynx is restricted due to this tracheostomy tube. It's called a nailing effect of this tube. So we have to evaluate the swallowing function of this baby. Some childs may tolerate oral feeds, for others we may need PEG, PEJ or nasogastric tube initially. And now coming to the complications of this tracheostomy. While the tracheostomy related deaths are uncommon, complications of tracheostomy are not infrequent. These general complications include accidental decannulation and tube blockage. These two can occur anytime after tracheostomy. And other than that, these tracheostomy complications can be classified as early and late complications. Early complications are in the immediate post-operative period, that is occurring within the first 1 week of this procedure. Early complications include hemorrhage, damage to the posterior tracheal wall or esophagus, pneumothorax, pneumomediastinum, or subcutaneous emphysema. So what should we do if an accidental extubation or decannulation occur? If an accidental extubation occur, we should first attempt in reinserting the tracheostomy tube of the same size. If the same size tracheostomy tube we cannot insert, we can attempt with a smaller size tube. And if it is not going, we can try with an endotracheal tube through the tracheostomy site. This endotracheal tube has a beveled end, so it is much easier to insert into this stoma. If this method also fails, we have to do this endotracheal intubation to save the life of the child. This tube obstruction is another complication. There may be partial or complete obstruction of the tube. So how will we identify if there is an obstruction? We have to look for the air entry, this air blast, this misting. And if the child is, look at the child for any respiratory distress. And we first we should try suctioning the tube. Suctioning can be done once or twice, maximum 3 times at a time. And if it is not improving or the secretions are not coming, it may we can do this repositioning of this neck, because this tip of this tracheostomy tube may hit and occlude the lumen by hitting the anterior tracheal wall. So some manipulation of the neck, this extension of the neck can cause this relief of this obstruction. And if none of the method, if a child still has some obstruction or distress after these two maneuvers, what we should do is immediate extubation. Can be life-saving for this baby, and reinsert with a new tube. If reinsertion is also failing, keep the child's neck extended and bring the child immediately to the nearby hospital. And regarding the late complications are either tracheal or stomal granulation tissue formation, peristomal infection, lower airway infection, localized tracheomalacia or stenosis. This tracheostomy can be done for this tracheomalacia or stenosis, but as a complication of this tracheostomy itself, it can cause tracheomalacia and stenosis. There can be speech delay or olfactory disturbance later, and persistent tracheocutaneous fistula post-decannulation can also occur. In this picture, first picture, we can see due to poor stomal management, there is a stomal infection with cellulitis. Here, due to the tight cord, there is skin breakdown. And in this picture, here there is suprastomal collapse, and here suprastomal granulation tissue formation. Here, peristomal granulation tissue formation, and tracheocutaneous fistula post extubation. So, when do we decannulate the baby? What are the indications for decannulation, or at what time can we do this decannulation? For decannulation, first we have to check if the initial problem has been resolved. That is, why did we do the first tracheostomy? What was the indication for the tracheostomy? If that problem is resolved, we should analyze the airway, examine the airway for any complications related to the tracheostomy, like the stenosis, granulation tissue, etc. And if the airway is also clear, we can downsize the tracheostomy tube. We can downsize to the smallest size tracheostomy tube, and if the baby is tolerating, we can try removal of the tracheostomy tube and observe the child in ICU for minimum of 48 hours for any development of respiratory distress. And if the child is stable after 48 hours, we can discharge the baby safely to home. So, discharge planning for a baby with a tracheostomy is a lengthy procedure and a detailed procedure. And we have to prepare the family for the procedure. And we should tell them the anticipated complications and how to address all these complications, how to care the tracheostomy tube, how to prevent this airway obstruction, regular suctioning, stomal care, and all. And the caregivers, all the caregivers, not only the parents, but who all are caring the baby, should know the tracheostomy care and how to manage any complications if it occurs. And the basic resuscitation should also be taught to them. And at every home with a tracheostomy child, there should be a tracheostomy kit available. Before discharge, we have to ensure that all these things are ready with the baby. And the parental teaching the parents should commence on the day of this tracheostomy itself. And even if the child is in NICU, we should ensure there is active parental participation in caring the child, and they should know what are the expected complications and how to address all these complications. So before discharging, we have to give them emergency card or crisis card where all the emergency numbers are there, and the nearest local healthcare facility should also be communicated. And so there is a multidisciplinary team approach for after the discharge of the baby with tracheostomy. Also, we have to ensure a regular follow-up of the child. We have to monitor the growth of the child and feeding pattern of the child. In this multidisciplinary team should include the neonatologist or pediatrician, ENT specialist, sometimes many critical care doctors, and speech and language therapist or respiratory therapist, etc. So in conclusion, for every child with tracheostomy, it is actually a safe procedure. The procedure is actually safe. The major part is the caring of the child after the tracheostomy. So parents should be taught effective care of the tracheostomy tube with stable support from the medical team. Thank you.
Archana, you can involve Ragitha, doctor.
Okay, sir. Madam, Dr. Ragitha. Hello, madam.
Hello. Hello. Am I audible?
Yes, Ragitha.
Yes,
Yeah, good evening, sir. Good evening, all. Yes, sir. So, it's well presented, Dr. Anjana. I would just like to add few more just points, sir. Hello.
hello, ma'am.
Hello. Am I audible? Am I audible?
Hello. Yes, ma'am. Yes, ma'am.
So, few more points like as regards neonatal tracheostomy. One thing, as Dr. Anjana said, that yes, the care is far more important and as compared to, and far more difficult also as compared to doing the procedure. So the care without a proper team, I think we shouldn't even consider a tracheostomy, a neonatal tracheostomy for that matter. In fact, the books also state that without a perfect team there, the tracheostomy shouldn't be ever performed. That's how the books also mention. So what is needed definitely is that the staffs are well trained, and it should be a continuous process. The way I have very well evidenced and witnessed in under Naveen sir's team in our ICU setup here. And second thing is that the decannulation plan, what I feel is that it starts right at the time of the surgery, because from that point itself, or rather from before the surgery, the decannulation, the percentage of the successful decannulation matters, in the sense that very prolonged intubation can lead to tracheal anomalies, tracheal damage, which might prevent a decannulation. A tracheostomy which is done improperly, in the sense the high tracheostomy, or done just below the cricoid, or even through the cricoid, or high damaging the cricoid, and causing severe cartilage damage, those cases. So that can actually later on lead to decannulation issues. And again, the care, if the care is inappropriate, like a very vigorous suctioning can itself induce too many issues. It can actually induce tracheal granulations also, if it is not done, as Dr. Archana said, if it is not done after measuring the length of the suction catheter being introduced into the tracheostomy tube. If it is done too deep, causing tracheal mucosal damage, in those cases, granulation can ensue. Again, a cuff deflation, which is of utmost importance, I think stressing it even 10 times more wouldn't be wrong. So, like that cuff deflation every 6 hourly for 10 minutes, so as to prevent a tracheal necrosis, so as to prevent a later on a tracheal stenosis, which in case happens will lead to a permanent tracheostomy unless a definitive airway surgery is done for the child. So all these parameters. So I think for decannulation, apart from the criteria which Dr. Archana has said, I think these are all the other parameters which equally play a role. And definitely the tracheostomy care, that is one of the most important things. Again, I think swallowing, just to add on, tracheostomy, we say, when we are taught, we say it is one of the indications to prevent aspiration, and it is aspiration is one of the complications of tracheostomy as well. So, what we often suggest is that we often do a FEES. What Dr. Archana was saying, laryngoscopy, we call it FEES. It is flexible endoscopic evaluation of swallowing. So, we do that to assess the swallowing and the airway at the earliest. Once the child is ready for, neonate is ready for decannulation from the neonatal side. And once that's done, because the tracheostomy kids, the neonate, the swallowing is impaired in 3 ways. One way is that the subglottic pressure is lost because of the tracheostomy tube sitting in the trachea, causing a puncture in the trachea, which leads to aspiration, makes the neonate prone to aspiration. Secondly, it impedes the laryngeal elevation. It causes a nailing in effect, we call it. And thirdly, if it's a cuff tube, which we use less often. If it's a cuff tube, it can cause esophageal pressure, causing again swallowing impairment. So I think rest all was covered well, sir. Anything more we can probably discuss?
Naveen, sir.
Can we invite questions from the audience? Chat box. Okay, fine. Any questions from the audience side? Shobha, madam, any suggestions, madam?
Good evening, Binu.
Good evening, madam.
Good evening, Naveen also. Because right now we are, I thought I will attend the session because right now we have a baby with tracheostomy in our NICU. It was a 25-weeker born with 720 gram. But now the baby is 7 months old with all the probable complications like neurodevelopmental delay, BPD, and other problems. So the baby had to have prolonged ventilation. And then now the baby is on tracheostomy for the past 2 months. I think I consulted Dr. Hari also, and also I think I sent the video to Dr. Ragitha also. You may be remembering, and it
Yes,
was
ma'am.
looking like a bilateral adductor
Okay,
palsy also. So
yes, ma'am.
tracheostomy is tracheostomy done, and now the baby is on tracheostomy for the past 2 months. We had a big struggle to get the tubes because it is not free for the patient. They had to buy it. They bought one cuffed one and one uncuffed one, and the baby is now this one, no, 4 kg, and when the baby moves, this came out so many times. So we had a struggle to reintroduce the tube because for us it was the pediatric surgeon who does the tracheostomy. It is not the ENT surgeon. So pediatric surgery resident only comes, and then she said she will do it tomorrow. It was a very big issue. Could not cannulate after about 12 hours. The tract was closed. It was decannulated in the night, and next morning only we could introduce. So in between we intubated the baby with the tracheostomy tube away. So few issues were there, but now the baby we have, but the parents are not very cooperative to take the baby home. They say they will take the baby home only when the tracheostomy tube is removed. So we are in a very big dilemma now, and we started counseling them, asked them to do the suctioning, changing the tube, everything. But I don't know how long we'll be able to succeed. I think the resident who manages this case is with us. Dr. Prakash is there. Prakash, what were your problems? I think Prakash has left. So this is the condition of the baby now. Its secretions are increasing, oxygen requirement is increasing, and we are continuing with OG feeds only, not able to swallow. The baby is not able to swallow properly because of the neurodevelopmental issues.
Good
Later,
evening,
the
ma'am.
scope was.
Sorry, Ragitha, yeah. Go ahead.
Sorry, sir.
No, go
I
ahead, please,
just want to
Ragitha.
know, sir, the scopy, a follow-up scopy was done, ma'am? Like recently a follow-up scopy or anything was done, ma'am?
Yeah, it was done. Now the airway upper part is improving. Movements have come, but not complete.
Okay.
But
Maybe in a
now the
month.
lung also is not very good. No, the oxygen requirement is increasing, decreasing.
Okay.
That way we are not able to. A few days we could do the bubble CPAP support, but now the baby requires ventilation in the connection through the ventilation only, and the echo shows some pulmonary hypertension also.
Okay.
So many complications are there.
Probably he needs the tube for other matters as well, ma'am. If I understood correct.
Yeah, now we got one more tubes. With difficulty, we get some charitable people. They gave the second tube.
Okay.
Yeah, I think, ma'am, you're right that the success of tracheostomy would depend on the underlying condition also. if we see 90% of tracheostomy, which is done for non-neurological conditions, most of them are out of tracheostomy in infancy in 1 year or 2 years. And for them, it's a life-saving procedure. It changes quality of life of the family
Very true.
dramatically. But here you have two additional issues. Maybe it's an extreme preterm brain, which is already either intact and developing or having issues, and the lung is also a problem. If we look at our experience with tracheostomies, I would the only reason for making this presentation today is to highlight that
Yes.
when the patient is selected appropriately, most of our babies have had a dramatic change in their quality of life, and life has survived from a situation where nothing was possible. In this year itself, we have seen 4 cases, I remember, where babies were struggling to even lie down, breathe, or feed. And after proper selection, after a effort to make sure that we are doing the right procedure, the procedure part, Ragitha, makes it look so effortless and so easy, and the baby comes back. From there, we have learned that parents can learn the procedure. We all are scared the tracheostomy, how will they manage? I can't remember a single accident in the hands of parents, either in the ICU or after going home. So it is a procedure that can be managed by parents at home. Although tracheostomy tubes are not easily available sometimes for smallest babies, but the costs are not unaffordable given that we spend so much on intensive care. And at least 80% of babies have done well neurologically because their primary condition was good. And they didn't get sicker because of the tracheostomy procedure. They all did, quality was very good. Parents have done well. So if we can sensitize our audience to choosing a tracheostomy when baby is indicated, it is worth it. We should not be afraid of it. And that's all I have to say.
Just one point, sir. I just take this opportunity to literally, I think it's very, very important to stress the tracheostomy care team in the neonatal ICU. I touch wood, we haven't had any disaster with these small, even 2.5 tubes were used at one point for some babies, and none of them had even we get adult tube blocks for that at some time, but neonatal ICU has been, that's really commendable, sir. So that's only the bestest part of the tracheostomy thing at KIMS, sir. Yeah. And I think Dr. Prakash has 2 questions there. Cuffed and
uncuffed tube. Yeah. Which one is it you which one to use?
So normally we prefer uncuffed for neonates as far as possible, because cuff tubes are very damaging for the trachea as regards causing necrosis and stenosis. But there are times wherein we are doing it for prolonged ventilation, and then we need to discuss with our neonatal intensivist who has referred, and the anesthetist again. So if they want and they are insistent on a cuff tube, we do put a cuff tube at times, but we try changing it to the cuffless at the first instance when we get the thumbs up from the neonatal intensivist. Again, once they're off ventilator and at the earliest, these are the 2 criteria. And usually it is done before the stay sutures are removed. The stay sutures we tend to remove at 7th day at least, because we use proline sutures, which are going to stay there, which don't get absorbed. But proline sutures have the habit of inducing granulation. So we don't want them to be there for long. And 7 days is the time for the tract to mature completely. So the idea usually is, if at all they are on a cuff tube, usually by 5 days or so, most of the babies are off ventilators, what we usually see. In those cases, what we do is we go in for a tube change from the cuffed into the cuffless. At the same time, ensuring the parents are there so that they just get an idea of it, so that before discharge, if they go home with the tube, the second tube change becomes more familiar to them. And after the tube change has been done, the stay sutures are removed. So the stay sutures are kept there for just a safety, because of losing the airway in case. The problem with tube change is that the tracheal hole and the skin hole are at 2 different levels. And with the baby swallowing, breathing, moving, they often get mismatched. So there is a very high chance of it getting going into a false tract. And again, the stoma is so small, the opening is so small, it can get collapsed, narrowed. So that is really difficult. So actually, the thing is that once the tube is out, it should be reinserted at the earliest as possible. That should be the aim. So that's what I've seen here. Like usually, the neonatal people, the doctors who are in the neonatal ICU, they put in back the cuffless tube, or if not possible, they use the endotracheal tube to put it back through the stoma till the time we reach there for help, like that. So, and yes, the mucomix nebulization, that I think probably Naveen sir can answer better. Usually we use it for adults. We recommend for neonates, but I am not sure whether it's used in the neonatal ICU. I think saline is used more frequently to thin out the secretions, sir. Am I correct?
Yeah, we do use it on occasional situations. I remember using it for a baby with cystic fibrosis, not for tracheostomy, but for other reasons. So not that we can't use, but in preterm babies, we need to be cautious. It's anything that's instilled into the growing lung has potential for damage. And there are documented cases of cavitation of lung areas after using an acetylcysteine. So in bigger babies, probably 2 months, 3 months babies, if you are really faced with, but like Ragitha said, if you humidify the system well by using the proper nursing care, you may not land up in very thick secretions unless there is underlying lung condition like cystic fibrosis.
Any other questions from the audience?
Thank you, Binu. I'll ask
Yes.
Archana and yourself to wind up. If Anila is there, if you want to make any comments, Anila.
Dr. Anila?
I would like to thank Dr. Ragitha. She had taken her valuable time for coming to this presentation, and she had a lot of points which will be useful to us who are taking care of the small babies. And thank you to Dr. Binu, Naveen sir, Shobha ma'am, and Hari Prasad sir. And special thanks to Archana. She has taken a lot of effort for putting a lot of information on this topic. So it was a wonderful presentation. Thank you.
Thank you so much for the.
Thank you, ma'am. Thank you.
Thank you.
Sir.
Thank you so much for the input. Thank you. Good night.
Thank you all. Good night.
Good night, sir. Good night.